editorial team as the editorial head, the behind the scenes, and how much have you done? What all hard work has been put in.
Based on the NCST curriculum to having it right in our hands today. So from end to end, I was there. I mean, so that would be a long journey, and that's part of each and every book that we work on as part of the PhysioBrid series. So I leave it to you, the readers, to take it up from here.
Thank you, Dr. Divya. Sir, I hope your connection is stable now.
Yeah, it's better. It's better now. It's better.
Great. So let us proceed towards the panel discussion, fostering disability inclusive societies for advancing social progress. So we would like to start with Dr. Vijay Kumar. So please start the presentation, and for all the audience, you have the Q&A box at the bottom of your screens. We'll wait till the end so that we do not end up disturbing our panelists. We can take up your questions one by one. You can go on adding the questions as the talk proceeds. So please.
Good evening to all. I just request my slides.
Sir, I've requested the backend team. They're starting the presentation shortly.
Oh, thank you. Yeah. So shall I start now?
Absolutely, sir. Please go on. And as you direct, the backend team will go on changing the slides.
Yeah. Can you go to first slide, please? First slide. Yes. Thank you. So thank you for that opportunity. I have a talk about the disability inclusive society. Before I start this session, I just want to know the members in the particular webinar that we know that we got third T20 World Cup. So for participants, it may be looking for the facts. We got only two. No, how come sir is saying about third T20 World Cup? The message is very clear. The first T20 Women's World Cup for the blind people in November 2025, they got the World Cup. But the message here is, we know the cricket, Rohit Sharma, Virat Kohli, MS Dhoni, but I don't think in any of the participants in this webinar can name any one individual who has taken the T20 World Cup Women's. The message is, we know some facts, something happening in that particular society or particular group, but still we are not able to recognize them, we are not able to appreciate them. So that's the perspective still happening in the community. Next slide. So what's the paradigm shift happened in disability? Initially, it was told like a part of an individual aspect, like more of a medical model. It's a problem with the individual. So he has some disease, he has some health problem, and he's suffering from that. At the end, he has a disability. But the science and the literature has modified, or there is a paradigm shift happened from this medical model to the social model, and now we have what called human rights model. As is displayed in this slide, that disability inclusion, which is in the social model of disability, which talks about the interaction not only with the individual with the impairments and with the environmental and institutional barriers, along with the attitudinal. That's very, very important. So we should know the facts and how we are going to approach these problems. And internationally, the society or the inclusion of the disabled people in the society has been addressed by United Nations Convention on the Rights of Persons with Disability. So they have provided a comprehensive framework for promoting inclusion of these disabled people in the society. With respect to India, they have supported by law called Rights of Persons with Disability in 2016. Next slide. Can we go to next slide? Yes, thank you. The estimates. Please listen here. The estimates what was projected in this slide is from 2011 census. Okay. What it has been shown in that census? The estimated people of disability in India is about 2.2 crores. Almost, it's about 2% of the population have been estimated in 2011 census. And this rate is more higher for men compared with women. And what was the type of disability reported? It was reported more of with movement, speech and hearing. That means the population what they address in the disabilities with a more of elderly population. Hence, disability related to vision and hearing and movements has been highlighted more. With respect to other perspectives related to literacy and with the employment rate, hardly 40 to 50% has been highlighted for the disabled. You can see that the graph, total 2.2 percentage of total population of India in 2011 census. So this picture may change if you're going to have a census next year by central government. This is going to be increased in the amount. And even you can see that the rate is more higher in the rural areas. And more specifically, you can see the patterns are more similar for physical disability, seeing and hearing, which is most commonly reported in the elderly population. And even with respect to education level, only 50% of the disabled people are able to achieve some literacy level. And with respect to job related or the employment status, only 35% of them have some areas. Next slide. So what is the term a disability inclusive society means? That means people with disability have equal opportunities, rights, accessibility, and participation in every aspect of their life, including the education, employment, healthcare, transportation, governance, and social activities. That's a paradigm shift of what means that disability inclusive society means. Next slide. We'll talk about more of the key features of what it means a disability inclusive society means. Can you move to next slide, please? Yes. It starts with equal rights and dignity. It means what? Even in our clinical practice, we don't call them with name. We call that CP child, call that stroke patient. So we address them with disability. So that you should avoid it. When you practice also, you called that X or Y person with the challenge. A child with whatever the name, with the problems of CP. Better to have that dignity pattern, and they also have the equal rights, which has been extensively discussed with respect to 2016 law of the Rights of Persons with Disability Act. Accessibility. Even we can address in the present environment with respect to the Indian context. People going to a bus, a private bus or government bus, they don't have access to have wheelchairs. Even if you look for the public toilets, we have the entrance, but it's very challenging for an individual with wheelchair to enter into the public toilet. So these are some accessibility problems what we need to have presently should address for the inclusion society. And we should also need to have some development in the accessory with respect to the communication, like signing language, easy to read format, and braille signs for the visually challenged people. This should be addressed in the disability inclusive society. Next slide, please. What is inclusive education? This is more of talking about in pediatric population where we need to have that early intervention. After that intervention, they should also be able to access to their education. So we should have some kind of guidelines or to help their family members where they can be educated further or where they can accommodate further. So you should have a man force or the trained educators for them to achieve this particular inclusive education component. So there is the need for support services. And today in India, there are a lot of NGOs and even government resources are available to provide these services, which can be further discussed by our Dr. Kuldeep sir, and even one of our speaker, Chandu sir, also discussing about what are the services available to achieve this. And the next parameter, the next component is about the role of employment. It's very, very important, as we know that poverty and the employment are go hand in hand. Already they have a challenge with disability, and with that disability, they're not going to have any kind of employment status. That is going to indirectly end with poverty. So it has been reported in India, 20% of poverty is because of disability or the disabled people. So there is a need to have a skill development and vocational training. And even if they're going to have hire this patient, hire this subjects, they should have no discrimination in hiring the practice. It has been observed that a specially challenged person can do better work than an able challenged person in the work environment. Next slide. Healthcare and rehabilitation is very, very important aspect from physiotherapy perspective, because the individuals with this disability, they need to have the services. What happens in real practice is we have the accessibility with institutional based rehabilitation. That means the client are admitted and they are undergoing rehabilitation, but once they get discharged, we fail to have the follow-up, we fail to have the interaction with the family members, and we fail to have a community setup to know what has happened to them really, what are the challenges they're facing it, and how they're going to integrate into the social life. That need to be addressed in this healthcare and rehabilitation. That means we need to have a interdisciplinary team with including the family members, the individual, and the community to have a successful program. So this also includes the early intervention program and also the mental health support, basically the social psychology component, which should be addressed in the present practice. The other components are the social participation, which includes how we can integrate or how we can make these people integrate into their cultural life and the community life. Basically, they can also be given a chance for leadership and also decision making, which is very important for policy making decisions. And last aspect, what I discussed in the first, positive attitude and awareness, because we know we got a team who got T20 World Cup from women's blind team, but still many of them are not aware of this fact. Even though they are challenged, they can able to perform well and they can show their effectiveness. So that's the thing, we should have the positive attitudes and awareness. So promoting the respect, empathy, and understanding of their challenges. Next slide. So what is the role of physiotherapy with respect to this disability inclusive society? So we start with functional therapy. So I don't use the word physiotherapy. The physiotherapy should be more of in a functional context. So we can use the term called functional therapy. Make your client as much as possible to be actively engaged in the real life situation. This has further emphasized in the community-based rehab program, which has been developed in past 2 decades, which is effectively happening in Indian context also. And later, we also have a major role in providing the assistive devices, like we should screen and also identify which is the best possible tool for this client to be actively engaged in the real life situation. Also, it includes the vocational rehabilitation, health promotion. It's very, very important. It's not only for healthy individuals to be physically active, it also necessary for the disabled people to be actively in their lifestyle. So health promotion and disability promotion. Further, we need to also have to know about the patient rights and interact with the family members, what are the support teams they have, and we should also be a part of in policy making decisions. Next slide. So what this slide talk about is more of the inclusion society includes the availability of the individual, basically the disabled person, and how to make him participate in the program, and what all things he can achieve, and how we can support with the further things. Next slide. So basically the support system what we have presently, we have an app called Sugmaya Bharat app, and we have also other related institute like National Institute of Learning Disability and for Visual Disability. Basically this Sugmaya Bharat app, if you enter into that, it gives the entire like real lifetime assessment. As an AI tool, you can raise your concerns, you can lodge a complaint about the accessibility or other complaints related to your challenge. That can be monitored by the central government scheme. So that's very good app. Even we had experience of how it is working on in our setup. We have also other non-government organizations like we have the Samarthanam and we have APD and we have other things like Give India and Smile Foundations, which helps the disability challenged people. Next slide, please. Next slide. Next slide. Next. So the future direction of what we perceive from the present situation is right-based approach. That means we should promote that barrier, whatever is going to be, that's going to be removed, and inclusion of all sectors, which includes the health aspect, rehabilitation aspects, and assistance and support, which includes environmental modification and employment. Next slide. So I conclude my talk. As physiotherapists, maybe one of the integral part of a team, we are the main members to build a disability inclusive society, not only focusing about muscle strength or range of motion, to make their real life situation happen at their home and in work environment and in the society. Basically, we are looking for social inclusion and the quality of life. Thank you for this opportunity and thank you for the CBS team for this presentation. Thank you.
Thank you so much, sir. I'd like to invite Dr. Kuldeep Deka. He's the author of the book. There were some connection problems, and that's why he couldn't talk about the book. So first, sir, before beginning your presentation, I'd like you to please say a few words about the book.
Hello, everyone. A very warm welcome to all of you. So firstly, I would like to sincerely thank the CBS publisher family for all the continuous support and encouragement throughout the journey from the planning process of the book to the present day of today's release. So by authoring this book, what I have learned and understood is anyone can write a book if he or she wants to tell a story, if they have in some commitment, time, and the effort to see it through. So usually for any book, so what are the basically things we require? The first and foremost is the content, what the content should be. So in this book, so basically me and sir, Vijaya sir, initially first we have worked out only for the content, which took near about a week time. So that was our first thing. After that, the content development, so for near about 3 to 4 months, we have done only the review of literatures to looking on what is the update in the community-based rehabilitations going on throughout the world. So we have gone from many original articles, research articles, commentaries, updates, and all, and so on. And thirdly, only we have started writing the chapter and selecting the good and professionals contributing authors for our book. And that's how our planning was there and our process was going on. And today we have released the book. So the main unique features of the book is in this book, from first chapter to the last chapter, everything we have written in a very simple format. It is a very, very simple format, and it is a very clear and concisely it has been also placed. So this book, the chapter number 1 itself, it starts from the introductions and overview of rehabilitations. That is the most basic one. And we have ended the chapter with evidence-based practice in rehabilitations. So with this book is basically not only for the physiotherapy students, but any rehabilitation professionals can go through this book if they want to have an idea about what is exactly the community health. So The most unique features is the chapters are well organized. It was very simple with example, what are the governmental support, what are the non-governmental supports. Everything has been well added in this book. And this book I'm dedicating to all the rehabilitation professionals, students of physiotherapy, to of the undergraduate level, and even the entry level of postgraduates, so that before they start with the postgraduate program, they should be clear with all the concepts of community health. So I will be very happy if the people will at least read the book, so that they will be able to understand the main content of the community health. Thank you. Next.
Thank you so much, sir. I request the back end team to please play the presentation.
So before the presentation, I just want to say one more word. Dr. Kuldeep is the captain of the ship, and whatever inputs he has given, it has really made us a good thing, and we are very thankful to Dr. Kuldeep. It is his dream to have a book by a physiotherapist for physiotherapy students, and it has been fulfilled by the CBS. Thank you for it.
Thank you. So I'm starting with the presentation of community integration for person with disability. So we can have an inclusive society only when we will be able to emphasize more on community integrations. For any goal of rehabilitations, or the ultimate goal of rehabilitations always is the community integration. So in these presentations, I am going to speak on all the known factors only, but I will try to make it as much as simple, so that at least whenever we are approaching any patient, or for any disability or any patient with any impairment, at least we should be able to identify what are the important things we consider. So next slide, please. Okay. So before moving to the main part of the community integrations, first we have to go through a few facts and myths. So facts number: any disease can lead to a disability. Take example, any disease from a chronic illness like cancer, hypertension, diabetes, then mental health conditions like depression, schizophrenia, any injury, spinal cord injury, traumatic brain injury, genetic issues. You can take example of Down syndrome. So any disease can lead to disability, and that disability itself will affect the functioning of an individual. The second fact is the disability is not only from the disease. The disability is basically from the perspective of the whatever the health part or the physical or mental part has been affected because of the disease process, that is the health conditions, and the association with the personal and the environmental factors. So those are two facts in relations to the disability. Next is there are a few myths like no disability is permanent. So no disability is permanent is more of like we can say it's a medical and the legal framework. So any disability is always firstly or initially it will be a temporary. So disability we can categorize into temporary disability and permanent disability. But disability will only become permanent when proper intervention is not being taken at a proper time. So disability will never wait for time, or it will see the economy of the individual. So we have the potentials, we professionals have the potential to intervene for any type of disability, so that it should not progress into the permanent. Now the second myth was basically the CBR is exclusively for rural areas. That is a very wrong concept, because if you take example the hospital is also in a community. So community, if we see on the actual meaning of the community, is a specified geographical area. So when a person is sick in his or her residence or home, they will be going to an hospital. The hospital, they will have a few stay for those all acute care and all, and then again the person will get shifted back to the community. So that is what is basically the continuations of the care. So that we are going to see in the next slide, please. Next slide, please. Yeah. So that is what actually the continuum of care approach. So Take example, patient with traumatic brain injury, spinal cord injury, or any major trauma. So they have to be in a hospital for the acute care managements, and where they will be under the medical management, physical management, or all other supportive management will be there. So after once the patient's vital sign has been cleared, the person's function has able to achieve some function, then that person will get discharged from the hospital. So that person will return from hospital to the community. So that is one community. So the goals, whatever it is there in a hospital based setting for a patient, it will not get varied from the goals what the patient should have in a community based setting. So that is basically what is the continuum of care approach. The continuum of care approach is the primary concept for basically community integrations, because all type of care, whether it is an institutions or at a community or from any support services, the main target is to maximize the functional independence. And whenever the functional independence a person will be able to gain in terms of their self-care activities or other instrumental activities, then only the community integrations will be possible. Next slide, please. So the community integration is finally entirely based on the continuum of care, what the care a person is getting in a community or in an institution based rehabilitation. So it is basically the core principle, and most of the disability policies throughout the world, from developing to the underdeveloped country, their policy always state on the community integrations, and those policies are basically the right of person with disability for to live, work, and to recreate. So community integrations, when you're talking about exactly about a community integrations, it is basically comprised of the three terms. One is the community presence, next is the participations, and third one is the inclusions. Or other way you can say, when a patient is getting discharged from an hospital back to the home, so that will be only the community presence. So that community presence is the first step in the community integrations. Then we have to secondly check whether that person is able to participate in his or her self-care activities or the family roles and all. So if the patient is able to participate, then only the third part will be the inclusions. So for an effective community participations, it will start from the individual attributes to the organization support, and finally it will be an enhanced community and health well-being. Next slide, please. So the community inclusions. So first, initially community presence, then the patient should be able to participate, and third will be the community inclusions. The community inclusions, the definitions is very clear that it's an opportunity to live in the community and be valued for one's uniqueness and abilities like everyone else. So it is basically to identify the capabilities of the individual, and based on that capabilities we will be able to define more refined goals for the treatment. So ultimate goal of community inclusion is we want the person with disabilities should participate, would participate, and could participate. So there are few examples are given. Take example for should participate. They should be able to play. They should be able to participate in sports and recreational activities. They should be able to do the family roles. Then would participate example, they should be able back to their job. Would participate, you can say about the education, socializations. So those are the basically the goals of community inclusions. So we have to identify, once the person is getting discharged from a hospital or a rehab center, how is the community inclusions, and based on that we can frame more defined goals. Next slide, please. So this concept is not a new concept about a community presence, community participations, or it is a community inclusions. Only that there are a few changes are there. Earlier, the concept was more on the medical model of disability. The medical model of disability, it's basically clearly state that whatever the health issues or the problem it is there, it is from the individual part only. That means it is based on the, suppose any tissue is injured, so that tissue has created the reductions in the functions of the individual. So the medical model clearly emphasized that he give treatment and improve the functions. So that was only the limitations of the medical model. So they have not defined the other aspect. And sequentially what happened? the next phase it came, that is the social model of disability. So they said ki medical model, based on medical model of disability, the person will be getting treated, they will be getting rehabilitated, but the society will not support. There will be few barriers will be there, and those barriers will again further restrict the individuals for an active community participations. But now, since last 10 years, the concept has been changed, because now the main area to intervene any patients comes from the biopsychosocial model of disability. So this biopsychosocial model of disability is basically the combinations of the medical model and the social model. So this biopsychosocial model is very common one, and we all people are using, because we are assessing an individuals from all perspective. Next slide, please. So so the picture clearly has showed about the biopsychosocial model. So the biopsychosocial model means when we are examining a patients to understand about their disease state, so we have to know everything from the what is the age of the subject, what is the gender, what is the injury, what is the lesions, what is the severity. So those are the biological characteristics. Similarly, how much is the expectant of the individual, then how much is the belief, whether any other symptoms like anxious, depressions, then sociological factor, how's the family support and all. So overall assessment is required to understand that disability in a proper way. So the disability assessment or the disability evaluations, what we are basically doing is basically to identify the patient's medical conditions, what are the associated limitations, what are their restrictions are there in the physical and mental issues, and what area they are basically occupied earlier in the pre-disease state, and what are the future expectations. So a thorough holistic evaluation is required for each and every patient to have a clear understanding of their disability. Next slide, please. So this is the same example about a disability evaluation. So we can see here two arrows. One arrow is towards the upward direction, and then the other arrow is towards the downward directions. So upward directions arrow, so that directions arrow is entirely depend on our the healthcare professionals, because the more thorough and clear assessment we'll do for an individual, we'll be able to know about their health conditions, what are the limitations in their body function and structures, then whether any personal factors or environmental factors is limiting their activity participation. So activity participation is the disability. So if we understand about those things, definitely we'll be able to understand the lesions and the severity of the state. And with a clear assessment, then only we will be able to frame the goals of treatments. So our goals of treatment may be directed towards a short-term goals or intermediate goals or a long-term goals. So based on that goals, we will be able to define what rehabilitation interventions the subject may require in order to minimize their disability. So the rehabilitation interventions can be anything, that the traditional or the conventional one, or the most advanced therapy like robotic based or virtual reality, or if any, suppose the accessibility is less, then it can be go with a tele-rehabilitations. So more better assessment will more help us to define more better rehabilitation interventions. And whenever the rehabilitation interventions will be better, then definitely we'll get a downward arrow. So that means we are minimizing the disability. Next slide, please. So this is just one example I have placed in the slide. This is basically the World Health Organization Disability Assessment Schedule 2.0. So this is the assessment form by which it can be self-administered, by which we can understand the person's overall prospects. Take example, understanding and communicating. How's the understanding of the person and communicating towards the disease state? How much is their person's mobility? How independent they are in the activities of daily living? Okay, what are their socializations, their life activities, and where they want to participate. So this is a disability evaluations. So what I mean to say is basically we need to have a very good assessment, precise assessment to define what treatment or rehabilitation is required. And more better our rehabilitation intervention, then definitely we are placing the individual with disability for a better participation in the society. And whenever they will have a better participation, then definitely we will be able to make them reintegrate into the society. Next slide, please. Next slide. So, what is basically the take-home message? So, assessment is important to define the rehabilitation intervention. Rehabilitation intervention we can define when we will be able to understand disability well. So, for any assessment, what we need to know is what activities are limited because of the disease state, what are the capabilities, means what they want to able to do, what problems they are facing at present, which area of the body is affected, whether any secondary complications or any other problem is further restricting them, and what should be their home and the community situation be like. So community integrations we will be able to define only when we will address all the following with a proper assessment and with proper rehabilitation techniques. So community integration means we have got three directions. One is we want the person with disability should have a good family participation, work and productivity for earning their livelihood, or it should be based on age and gender specific. And thirdly is their socialization. So that's what about is community integration. So more better community integrations, then we will have a more better inclusive society. Thank you.
Thank you so much, sir. I now request Dr. Chandu to please join us for the presentation and request the back-end team to please play his presentation.
Yeah, am I audible, madam?
Absolutely, sir.
So, at the outset, I would like to thank Dr. Deka, sir, as well as Vijay Kumar, sir, for giving me this opportunity, and also the CBS team. Thank you once again. Yes. So, shall I begin?
Absolutely, sir. Please start.
Yes. So, successful community reintegration of the specially able, like what Kuldeep sir and Vijay Kumar sir have mentioned earlier about those concepts. It's not enough that a person gets rid of the condition medically and surgically, but he starts taking part actively back into his own personal care and also recreational and professional life. Next slide, please. So what is community reintegration? So we have to look at these important concepts or the key points, what defines this. So one is becoming the part of mainstream of the family and also the community life, and participating in normal roles and responsibilities, and also being an active and contributing member of one's social and society as a whole. Now, another important person discussed, so he conceptualized that this is an individual's capacity to resume the societal positions and the activities which are at par with their demographic characteristics, especially to say that within the community-based social networks. Now, why this is more relevant is because it aligns more with the international classification of the functioning, health, and disability. Next slide. So let us speak like what are the factors which are influencing positively as well as negatively this community reintegration. Now, I would here mention only about the points which are relevant to our nation. So one is there are accountability and the transparency which are a key factor, especially when the implementation of the disability welfare initiatives are concerned. Then the physical and environmental obstacles like public infrastructure, transportation, ramps, elevators, accessible restrooms, accessibility issues, especially for the wheelchair users. Then absence of the transportation for the people with assistive technologies, deficient healthcare and rehabilitation services. So all these things restrict the mobility and access. Attitudinal biases, like what Vijay Kumar sir spoke, that attitude is one of the most important things. So there are the social stigma and negative perceptions, discrimination in education, employment and community life, misconceptions of the disabilities, among the disabled themselves and also the society and the organizations which are working for the welfare. So they further exclude the disabled people from the welfare. Then informational gaps, like the formats which are of the content, whatever are available for the educating or in strengthening the disabled people, many a times they are inaccessible. So it becomes difficult, and also there is poor communication of the government services which limit the awareness and access. Next slide, please. Then the organizational constraints, which include that there is a scarcity of the trained personnel, adaptive support. So this overall hamper the services quality which are provided to the persons who are specially abled. Geographical disparities, especially the rural areas, which include the poor transportation, scarcity of the specialized services. Then cultural misconceptions, because there are traditional beliefs and also lack of awareness which further isolate persons with disability, which differ from area to area, community to community. Psychosocial challenges, so mental health issues, isolation, emotional distress, especially in the rural areas. And so all this, especially the combination of exclusion and inaccessibility, so all of these often result into anxiety and depression among the persons with disabilities. Next slide. Next slide, please. Yes. So continuing with the things. So overall, due to these issues, many a times they will face psychological barriers like depression, anxiety, failure, fears, stress, individual beliefs which don't let them grow, dependency and hopelessness. Then cultural barriers like negligence, isolation, gender biasness, social suppressing attitudes within the communities, discrimination, low social acceptance, social beliefs and practices, narrow-mindedness. Then coming to health condition and the medical condition related barriers. So there are physical problems like the pressure sores, pain, spasticity, the person is catheterized, or they have added infections, inadequate and improper treatment, improper, poorly fitting assistive devices like crutches, wheelchairs, etc. Next slide. So having spoken about this, let us shift our attention to what are the challenges as far as the physically disabled people face. So especially they face the barriers like public transport, infrastructure, insufficient accommodation within the educational and work environments, high costs of the assistive devices, especially the amputees, and overlooked healthcare needs. Then the specially abled people with sensory problems face a lack of interpreters, adaptive technologies, and accessible formats which hinder the communication and also access to education and employment further, which restrict their independence. Coming to the intellectual and psychosocial disabilities, is the misconceptions and the social stigma result in the exclusion of these people from the mainstream services and also inadequate mental health support. Next slide, please. Yes. So, what are the like already some of the points have been spoken by Vijay sir. So, the factors which have been there or they are present for empowering the persons with special abilities. So, technologies, so assistive technologies and inclusive information communication and technology which enable persons with disability to participate in the society more openly and more optimally, and employment opportunities and outcomes like skill development, workplace accommodation, enforcement of the anti-discrimination laws as per the International Labour Organization and also the government state as well as the national governments. Then government initiated schemes and the institution, like what was spoken earlier, like the departments which are working for empowerment of the persons with disabled people. So they offer research, training, and advocacy. Then digital access for unique identity for the disabled people, so which facilitates the digital identity for accessing the services. Then financial aid for, that is Financial Development Corporation, that is for the especially handicapped. Then Indira Gandhi. Next, Indira Gandhi scheme. Next slide, please. So we are having a number of schemes also along with the government, like Disha, Vikas, Samarth, Garonda, and Niramaya, to name a few of them. These are all supporting the rehabilitation and healthcare and social integration and reintegration of these specially abled people. So these are all schemes look at various aspects like development, coordination, monitoring committees, and also vocational skills, training, caregiving, Vikas centers or the skilling, enhancement of the skills of the persons with disability, housing and home for the persons with disabilities, affordable health insurance schemes, educational support, and rural livelihood missions and educational, uh, enhancing them for more inclusion, even including the education and training and employment, where there is 4% of job reservation in the government, which has been hiked from earlier 3%. Deen Dayal Disabled Rehabilitation Scheme for the skill development. Also, they have a lot of tax relief accessible India campaigns. So Manrega, which is on the verge to be renamed to offer the livelihood support. Next slide. Next slide, please. Yes. So, though these schemes are existing, but there have been identified research gaps, like lack of reliable data as far as the persons with disability scheme. Like, because the earlier census, which was as per the 2011, so almost 14 years have passed since that census has taken place. So still there is a lot of lacunae as far as the data in itself is concerned, and there is inadequate interministerial coordination and insufficient funding for the disability related programs. So what makes the schemes a bit ineffective as far as our country is concerned is underperformance, inadequate coverage, stagnant budgets, poor execution, implementation gaps. So all of them contribute to the ongoing marginalization of the persons with disabilities in India. Next slide, please. So, what we should remember is that though despite all these hurdles, together we can make a difference. So coming together and working for the welfare of the specially abled, because they are a part and parcel of our community. So as healthcare professionals, we need to give equal importance for these reintegration of these people. So all the stakeholders have an equal key role to play. Then enhancing the awareness of the, because there are quite a lot of changes in the past 5-6 years, the portals, the digitalization is concerned, the effective implementation, and from the government side, easing out the administrative channels so that the beneficiaries can take the maximum benefit and it is easy for them to access the benefit. Then collaborative activities, whether it is between the ministries, departments of the government, non-governmental organizations, the disabled people's organizations, and also the various other platforms which are working for the welfare of the specially abled people. So once again, I thank all the organizers. So I hope I have done justice to my topic. Thank you once again.
Thank you so much, sir. So before we move on to the next presentation, that is Dr. Divya's, I'd like to announce that we're going to have a lot of interactive session, question answers with the students, and winner announcement towards the end. So please go on typing your questions, go on giving your questions to us in the chat box, and we'll take them up in the end. And please stay tuned. Dr. Divya, I'd like to invite you to start with your presentation. I'm requesting the back-end team to please start Dr. Divya's presentation. Now, while Dr. Divya is connecting with us, there are some glitches on our end, and we're trying to reconnect with her. So, I'd like to tell you something about CBS Publishers. Recently, we've launched the eCBSPD app, and that is available for downloads. There is a lot of videos, a lot of e-content and academic content there. I'll request the backend team to please play the eCBSPD video once again. Thank you, back in team. So there is still some network connection with Dr. Divya. I request Dr. Apurva to begin with her presentation for the panel discussion.
Will I be going next?
Dr. Apurva, we can play your presentation first if there's some connection problem with Dr. Divya.
Okay, sure.
We're trying to get her to share the screen.
I have shared my screen. Are you able to see?
Yes.
Can you see my PPT?
No, Dr. Divya, you'll have to switch to the tab where the PPT is playing, yes. And please go full screen with the PPT.
Yes, visible now.
Okay.
Yes,
Yes,
visible.
that's fine. That's fine.
Okay. So, good evening, everyone. There was some technical glitch that my PPT was not playing. Today, I will be presenting the rehabilitation journey of a child with spastic diplegic cerebral palsy in the Indian context. This presentation will help us understand how rehabilitation is not only about physical treatment, but also about family involvement, community participation, and inclusion. We will look at a child's condition through a case using a structured and holistic approach. Next slide, please. Oh no, I have to do that.
Dr. Divya, it's on screen share. You will have to change the slides now. Please press enter, it will change.
Yeah. So this case is of a 6-year-old boy diagnosed with spastic diplegic cerebral palsy. He lives in a semi-urban area in India. The main challenges faced by him include increased spasticity in the lower limbs, delayed mobility and balance, and limited participation in school activities. The family's goal is very clear. They want the child to walk better, attend school regularly, and be included socially like other children. So this is the description of the health condition of the child as per the ICF framework. Health condition is cerebral palsy of the spastic diplegic type. Spastic diplegia is a type of cerebral palsy where the lower limbs are more affected than the upper limbs. This is not an exhaustive problem list or description, but an example of how the ICF framework is useful in rehabilitation and inclusivity. Talking about the body structures and functions that are affected in this child, there is increased muscle tone and spasticity in both lower limbs. There is reduced selective motor control along with muscle tightness and weakness. These factors affect postural stability and make functional movements difficult for this child. Because of these impairments, the child has several activity limitations. He finds it difficult to walk independently and maintain balance. His gait is inefficient and he gets tired easily due to reduced endurance. Activities like climbing stairs, walking on uneven surfaces, or even standing for long periods of time are especially challenging. These activity limitations in turn lead to participation restriction. The child has difficulty moving independently in the classroom and participating in playground activities. His involvement in sports, peer play, and school functions is reduced. As a result, he becomes more dependent on caregivers for mobility related activities. Environmental and personal factors play a very important role in such cases. Barriers commonly include inaccessible school infrastructure, such as stairs and uneven flooring, limited playground adaptations, and inconsistent access to rehabilitation services. At the same time, there are strong facilitators. This child has a supportive family and access to physiotherapy services at the district level. Personal factors become all the more crucial in this case, as the child has a good learning potential, preserved cognition and communication skills, and high motivation to participate in school and play. Inclusive rehabilitation works at all three levels: the individual, which is the child in this case, the family, which is mainly the parents in this case, and the community or society at large. For the child, rehabilitation aims to maximize functional abilities and independence. For parents, understanding the condition and supporting rehabilitation consistently is essential. For society, inclusion means providing equal opportunities, accessibility, and participation for all children. From the child's perspective, rehabilitation focuses on reducing disability and improving function. Physiotherapy addresses lower limb spasticity through spasticity management, strengthening of postural and anti-gravity muscles, and of course, gait and balance training. Preventing secondary complications such as contractures, deformities, and reduced endurance is also important. Mentally, children with spastic diplegia often have age-appropriate cognition and communication. Therefore, physiotherapy should also aim at building confidence and enhance social development. This can be done by encouraging independence in activities of daily living and promoting participation in play, school, and peer interactions. From the point of view of parents, parents play a key role in successful rehabilitation. They need to be educated, first of all, that cerebral palsy is not a progressive condition and that early and consistent rehabilitation is important. Parents should be guided to set realistic and functional goals rather than expecting a complete cure. Their responsibilities include following home exercise programs, carrying therapy goals into daily routines, and ensuring regular follow-ups. Acceptance of the child's condition is essential. In my experience, this is usually the first and one of the most challenging steps in rehabilitation amongst the pediatric population. Reducing overprotection helps the child become more independent. Parents should also identify and encourage the child's strengths, such as cognitive abilities, communication skills, or his interest in academics and arts. The diagram on the left is a summary of the role of the parents that they can play in inclusive rehabilitation for this child. Society plays an equally important role in inclusion. Barrier-free environment, like Dr. Chandu spoke, should be created in schools, playgrounds, and community spaces. Teachers, peers, and community members should be sensitized to reduce stigma and any negative attitude towards the condition. Support systems like community-based rehab services and government schemes under the RPWD Act should be utilized, Again, Chandu sir spoke about some of the government schemes. Advocacy for inclusive education and equal participation is essential. Inclusion is a human right. It ensures fairness, dignity, and equal access for all individuals. I'm not going to talk about inclusion as this topic was already covered by Vijay sir. For children, inclusive environments improve social skills, confidence, communication, and independence. For society, inclusion reduces stigma, promotes empathy, and creates stronger, more compassionate communities. Overall, inclusive rehabilitation benefits everyone. This image shows the inclusive rehabilitation using the CBR matrix, showing how a child with disability can be supported holistically across 5 key domains to achieve participation and inclusion. Health focuses on physiotherapy interventions such as spasticity management, gait and balance training, home-based exercise programs, and appropriate referral to secondary and tertiary care services. Education emphasizes inclusive schooling through classroom and mobility adaptations, teacher orientation, peer sensitization, and flexible academic accommodations. Livelihood highlights early development of functional independence, preparation for future vocational skills, and prevention of secondary disabilities to support long-term productivity. The social domain encourages participation in play, festivals, and community events, creation of accessible community spaces, and awareness programs to reduce stigma. Empowerment focuses on parent training and counseling, promoting the child's independence in activities of daily living and advocacy for the child's rights. Overall, the image conveys that rehabilitation is not limited to therapy, but requires coordinated action across health, education, social and empowerment sectors to achieve meaningful inclusion and quality of life. For a detailed understanding of the CBR matrix, I encourage students to refer to the book Community Health Perspectives for Physiotherapy Students that was released today during the webinar. And I would conclude by saying that rehabilitation of a child with spastic diplegia is not just about physiotherapy sessions. It is about empowering the child, supporting the family, and building an inclusive society. Thank you.
Thank you, Dr. Divya. I next request Dr. Apurva to please begin with her presentation.
Okay, while I wait for the presentation to upload, I was going through the chat and there's certain discussions happening amongst the speakers, the students who are participating, that which is more challenging, is MPT, ortho more challenging, neuro more challenging, etc., etc. The challenges does not lie with the specialization. The challenges lies with the patient who is approaching you. So rather than seeing what stream is more challenging, go follow your passion, and every patient comes with their unique challenges. So try your best to address that. So good evening, everyone. I will be discussing a case on inclusive rehabilitation after spinal cord injury, taking it forward from whatever our previous speakers have spoken. So we saw what is inclusive society, what is community integration, what are the various challenges you face, and you saw how a picture would be for cerebral palsy child. Now I'll be taking the similar approach for an adult case, and here we'll be referring to spinal cord injury. Next slide. So as physiotherapists, our roles does not stop at improving muscle strength or mobility. We also are responsible for helping a person with SCI to reintegrate into the society, return to meaningful roles, and live with dignity. That is very important. So through this presentation, we're going to see how physiotherapy helps with community-based rehabilitation, and what are the Indian disability policies which work to support inclusion. Next slide, please. Okay, so this is just a case to help you frame the picture better. So we have a 23-year-old male with traumatic spinal cord injury at say T10 level, resulting in paraplegia. So he lives in a semi-urban area in India, and due to injury, he has impaired mobility, reduced endurance, limited participation in social and vocational activities. So the main goal for this patient is that he achieves independent mobility, has returned to work, and active participation in the community. Importantly, his rehabilitation should be guided by the Rights of Person with Disability Act, as mentioned by Vijaya sir in the very beginning of his presentation, which focuses on dignity, accessibility, and equal opportunity. It means that we recognize the person as a rights holder and not just as a patient, as Divya ma'am just mentioned about human rights. Okay. Next slide, please. Great. Now, whenever we are approaching any patient or any case, it's always good to take in the ICF because it helps you get a better ability to understand what we are dealing with. So it gives us an overall better understanding of the disability. At impairment level, this patient is paralyzed at D10. So it will result in poor trunk mobility and risk of complications like pressure sores. At activity limitation, he has difficulty with transfers, wheelchair mobility, and reduced endurance. And at participation level, he will be affected at his work, education, recreational, and social life. So environmental barriers and gaps in policy implementation are also there, which further reduce this patient's participation in the community. Okay, next slide, please. Yeah, so disability is not only just the injury, but it is also the environment. This is just how you see in an ICF framework how you approach the case. Okay? Using ICF helps clinicians and patients capture the full impact of spinal cord injury, which is beyond the medical impairment alone. So in this example, we can see how your ICF domains are linked to impairments, to activity limitations, and it will help us guide your rehabilitation goals so that we achieve participation outcomes and standard measures are used for research and policy implementation. ICF also serves as a tool for communication to involve patients and family in the your care planning. Next slide. Next slide, please. Right, so we've all talked about barriers, right? We know there are various barriers that prevent patients with spinal cord injury from reintegrating. So some of the common barriers that you see are physical barriers like inaccessible buildings, which was again talked by our previous speakers, public transport, toilets, footpaths, etc. Then you have gap in your services, which was again spoken by Chandu sir. I'm not going to go into more detail into it. And then there are social barriers, including stigma, awareness, lack of awareness about the disability, and attitude that promotes dependency rather than your independence. Now, for all the audience over here, I would like you to answer this question that I'm going to put forward. You can use the chat to give your answers. What barrier do you think affects the patient more? Is it a physical barrier or is it a societal barrier? Can we start having some answers in the chat, please? Next slide. I'm just waiting for some of the answers to pop in. Fantastic, fantastic. Absolutely. Good job to all our audience. They are actually listening. I'm happy. So more often it is your social barriers which are the ones which create more of an impediment to integration rather than your physical barriers. Because your physical barriers can be reduced. Negative social attitudes and stigma continue to hamper participation. So this shows that inclusion not only requires ramps and facilities, but also a change in the mindset. So over here, you can see I've jotted down few of the barriers. Already our speakers have spoken about it, but clearly you can see anything which is physical, like say nature or human-made obstacles to the environment, we can change it. If there is a problem with technology or products like maybe transportation, you can modify the transport for a spinal cord injury patient. You can assist them with technology. However, when it comes to attitude and beliefs, that's where the main challenge lies. So good job to all our audience. Great. Next slide. Okay, now this is a very brief outlook of what you're going to look into assessment and goal setting. This is not exhaustive, but in the forefront, you should think under these headings, right? So proper assessment is essential for planning inclusive rehabilitation. First and foremost, you have to tackle your neurological assessment. So for spinal cord injury, immediately you should think about Asia scale, trunk control, spinal cord, your wheelchair skills, and you need to look into transfer ability. You can use outcome measures like wheelchair skill test to help you track how your people is progressing. And goals are according to the very focus on participation, accessibility, and dignity. And documentation is must because later when you can go for disability certificate for access to government documentation is right. Please. Thank you. So this is a outline of our physiotherapy intervention would be there. Right? So have to focus both on function and prevention. Okay. This includes pain management, assistive management, management, contractual management. You focus on functional training.
Dr. Apurva, I'd like to stop you for a minute, please. There's some problem with your network connection. The voice is fluctuating and people are writing, they're not able to hear you.
Etc.
So our backend team is checking the network problem. Audience is requested, as soon as you're able to hear us properly, please start writing that you're able to hear us.
Hello.
6, 7.
Dr. Pura, now it's fine. If you could continue. Please continue.
Am I audible now?
Yes, now it's fine. Please go on.
Okay, so I'll just repeat this slide.
Yes.
Is it clear now? Dr. Ashi, am I audible now?
Yes, absolutely clear.
Okay,
but you'll have to repeat this slide
right.
because, and I think the previous one also, because there it was not clear.
Okay, you can take it to the previous slide then. Okay, quickly. So just the previous slide, I talked about goal setting and assessment. All right. So assessment and goal setting, this is again a very small snapshot of what is actually expected. So the forefront of it, you need to do a neurological assessment, which will include ASIA, trunk control, spinal cord injury assessment, okay, wheelchair transferability, outcome measures you will use like SCIM, FIM, and you will track your functional progress with how the patient is going about with his wheelchair skills. You have to ensure that your goals are set as per your RPW Act for ensuring that there is participation, accessibility, and dignity. And documentation is a must because with this documentation, only when the patient is going to go to achieve, like attain certain government benefits, or he is going to go for support with your disability certification, that's where your documentation plays an important role. Okay, are we clear? So proper assessment is really essential for planning inclusive rehabilitation. All right. Okay, next slide, please. Right. So physiotherapy intervention, this is again a very small snapshot. It focuses both on functional and prevention of complications. All right. So you are going to look into pain management, spasticity management, pressure shock prevention, contracture management, etc. Functional training focuses on transfers, your wheelchair skills, balance, and working on the patient's endurance. Home exercises is essential so that the continuity of care is there. Like Kuldeep sir has mentioned, that care continuum should be persistent with patients with long-term disability. And physiotherapists also coordinate with your district level hospitals or NGOs to ensure long-term rehabilitation. Next slide. Okay. So again, CBR in India is it's a topic which is very vast because the Indian diaspora is very vast. So for this case of spinal cord injury, for health related, physical health related conditions or issues, you need to ensure continued physiotherapy, maybe through telerehabilitation or through the help of district level services, which I just mentioned. For education and vocation, you have to redirect the patient towards vocational rehabilitation centers and Skill India programs to help them return to work. Social empowerment involves peer support, self-management, and NGO participation. Local governance ensures access to resources, inclusive policies, and community-driven initiatives. For example, in Tamil Nadu, there is a NGO by the name Soul Free, which is offering rehabilitation training and peer networking. So, such communities are needed for inclusive participation for SCI patients. Next slide. Okay, so to sum up, persons with spinal cord injury, they form a heterogeneous group due to differences in injury related factors. So whenever you come across any patient with SCI, this is a simple module to follow through with your individual assessment. Okay, so you look into individual aspects like injury related factors, personal characteristics, and socio-environmental conditions. Then these factors influence each individual's functional abilities, coping capacity, and access to support systems. Therefore, community integration must be planned through multiple approaches, including physical, psychosocial, and vocational rehabilitation. Together, these approaches, they aim to restore mobility, social participation, emotional well-being, and create a productive role. Okay, next slide. All right. Now, this this is again an image, a multi-level framework, which helps you judge whether your community reintegration was successful or not. Okay. So at the client level, rehabilitation focuses on counseling, education, self-efficacy, and skill development. And leasing it, if it is happening positively, it is going to lead to a behavior change, such as improved acceptance of their disability, better coping strategies, increased motivation, and independent decision making. At community level, you have to have awareness programs, environmental modifications, engage with leaders, schools, employers, etc. And if you're going in the right direction, you'll see a behavior shift happening with reduced stigma, more social support, more social interaction, inclusive attitude, and thereby improving participation and reducing social isolation. We all identified that social barriers are more important, right? At the government level, inclusive policies, accessible services, transport facilities, employment support, etc. And if you are heading in the right direction, you will have institutes move from exclusion to inclusion, routinely considering accessibility, participation, and rights for the person with disability. Together, these behaviors across individual, community, and system, it leads to successful community reintegration. Next slide. Okay, so this has already been talked by previous speakers. I'm not going to spend much time on this. So these are a few of the inclusive frameworks given by India, which helps reintegrate such patients. So the final outcome is that we need to have participation, independence, dignity, and social inclusion. And as future physiotherapists, our role is not only clinical, but it is also for social and advocacy based. So thank you so much. With this, I end my presentation. Thank you for your patient listening.
Thank you so much, Dr. Apurva. So that was our presentation by our panelists and experts from the field. And I now open this panel discussion to the students for their questions. So we have a lot of questions coming in from the students. I'll go on reading them one by one, but again, because I am not a subject expert, I'd like the panel to decide themselves who would be answering the question. So I'll go on reading them, and please answer the questions. So the first question comes from Rachna Vashisht. How to study orthopedic subject, because it is very difficult to remember everything. Please tell us, because ortho practical and theory both are very tough and very vast syllabus. So open to the panel. Who would like to answer?
See, basically, when you talk about the subject, any subject, it may be ortho, neuro, and all. Okay, you should not initially first think the subject is tough. So what you have to do first, you need to have a planning process. Which topic you want to read, and you should have basically the textbook. When you have a 2 or 3 textbook or reference book with you, then you read from all the different 3 textbook, get the basics, and then you try to see whether it is applicable or not. That is the one way. Second way is preparing notes. Sometimes few things you may need to prepare notes, but preparing notes may also sometimes may take time. So what you need to do is, from 2 or 3 different books, what you can do, you can prepare one algorithm or flow chart. This is the conditions, this is the etiology of this one, this is the diagnosis, this is a special test, and this is the treatment, and what are the recent advances are saying. So if you prepare a framework or in an algorithm way of any topic, then I think it will be easier for you to understand.
With my perspective is what the earlier speaker was discussing about the passion. Okay, it is about your passion, like which area you want to explore. All areas of specialty, they have pros and cons. It's not like neuro is best or ortho is tough. It's not like that. It is about your passion. Like once you practice your undergraduate level, there is always some inclination happening within yourself. This area I want to explore more. That's the way you start your PG program. So PG program is more of, you want to be more focused. What I want to next to carry over in my career. With respect to orthopedic, it's like, as you said, it has many branches, including that. which has the manual therapy approach, sports therapy, so hand rehabilitation. It has many wider scope of understanding all these things. So, to my perspective, what I can suggest is like make your patient, and if your passion is towards the orthopedic area to explore, then always it won't be a challenge for you. It will be more of exploring the things and getting into more and more knowledge into your field, and that makes you more successful in your career.
Thank you, sir. Any other panelists would like to add to the answer, or I should proceed to the next question? Chandu sir, please unmute yourself. We're unable to hear you.
Yeah, like what sir said, if the person can make more like a practical approach of studying, like looking at the patient's models, x-rays, so that would help them remember a lot of things from orthopedics point of view. And as such, keeping in mind that all the systems are equally important and all are equally supporting each other, because every cell of the body is a part of the body, and so we have to take the entire comprehensive look at a entire human body, including the mental aspects.
Thank you, sir. So there you go, Rachna, you have your answer there. The next question comes in from Neha. How can physiotherapists balance impairment-based treatment with activity and participation goals in disability management?
So that is a very good question. And so basically what is important is your understanding of the conditions of the patients. So for a better understanding of the condition of patients, so you need to do a thorough evaluations, or you can say as assessment or examinations. So when we are talking about the impairment, to understand an impairment, we have to go through both subjective and the objective examinations. So when you have a clear subjective, means what is the problem, how it happened. Okay, so one thorough assessment, what are other medical conditions, whether any similar episodes was there in the earlier. So all those subjective, the informations what you have to collect or gather from the patients, that will help you to define what objective examination you need to do. And that the objective examinations selection will be entirely depend on your subjective examinations, and based on that, whenever you do the objective examinations, with that examination you will be able to frame the problem list. Take example, you have done the assessment of tone or sensory. If there suppose there is a increase in tone or some sensory deficit, so those will be your problem list. So framing of the problem list you have to do. Once you have framed the problem list, then you can categorize it based on the ICF classifications. So ICF classifications categorization, one is your body structure and functions, activity limitations, and participation restrictions. So body structure and function is basically the impairment. So any loss or any changes in the structure of the anatomical, physiological, or psychological part. So whatever, take example, one muscle injury, biceps muscle injury. So bicep muscle injury will be your impairment. And when your bicep muscle injury is an impairment, then definitely you will see the range of motions may be a difficult either in active or passive. So that will be your activity limitation. So what you have to do, so you have to list down the body structure and function, activity limitation, participation restriction. And when you will be listing all those things, plus the collections of the informations of the personnel and the environmental factor, what you will be getting from your subjective history, will help you to define the everything. So that is exactly.
So I just add on few perspective of that question. It was interesting question as sir was said. What I need to address here is when you assess a client, for example, a case scenario of 30-year-old or 32-year-old having a profession of a teacher, had a stroke. When you want to assess this client, you should start with the participation level. That means what is his role as a husband, as a son, as a father, and as a professional he's a teacher. So when you look for at least one component of his participation, like he want to continue his job as a teacher, he need to use his bike, or he need to travel in the bus, or he need to stand for some time, and he has to do some fine motor activity of writing in the board or taking some attendance. For that one participation level to be as a teacher, he has list of activities. For that list of activities, you may have a list of impairments. That means we need to start the assessment from the participation level. Look for his role as a teacher. He need to stand for some time and write something in the board. Your activity looks for standing balance and fine motor skill. Then for each number of activity for that participation level, for example, standing balance, you need to assess for the list of impairments. So what we tend to practice here is like, the perspective of physiotherapist is, if I address the impairments, automatically the activity will get improved and the client will be participating in the society. But that is not the scenario. So we should go in a reverse way. We should assess on the participation level, look for the activities contributing for that participation level, and for each activity, what are the impairments addressing to that. Because here the practice pattern is one size fits for all. Any stroke patient comes, you have a list of things to be addressed to the patient. It doesn't work in our practice. It doesn't mean that one size fits for all. So you have to assess with the participation level, look for the activities, and for each activities you list down the impairments, and for each impairments you address your physical therapy interventions. Just go in the other way around rather than going from impairment activity to participation. That is my opinion regarding this.
Thank you, sir. Chandu sir, your bite, please.
No, ma'am. Both the teachers have given adequate inputs. I think it is sufficient.
So we'll move on to the next question. The next question is from Navjot. Is it true that MPT in neuro is more challenging than others?
So, as we know, one of the most complex system in the human body is brain. So, if you want to address the physiotherapy perspective in neuro rehabilitation, okay, it is more of like not only the physical parameter, even the psychological parameter come into the picture, because each area of brain contributes for some amount of your behavioral pattern and your personality. So to understand these features with respect to neuro rehabilitation per se, it's going to be a challenge. Why? Because the evolving trend in the literature and the science. See, now if you see the research, recent literature of the in the medical literature, last few decades or last 5 years, there are more studies on functional MRI, which has not been explored during my time. During my time, it was only that the assessment is more of the outcome based, like performance based. Now we have studies highlighting which part of brain is involved in a particular learning process, and which part is contributing for the memory, and which part is contributing for the functional outcome. So there are a lot of literature happening in the advancement in the technology and also in the method how to access these brain areas. That entirely changes the perspective of what you are going to address in the rehabilitation. So that's the big challenge for neurophysiotherapists is there is an upgrade happening in the way to assess the client, and there is an upgrade happening in the theories of motor control and motor learning. So that is going to be a challenge for the MPT neurospecialist, because if they're not going to update these processes, they can't going to implement a successful rehab program for their clients.
Thank you, sir. So this question has come from many different students, and they want to know about MPT specialization. You know, which subject is good and which would be difficult and all that. So if you could please tell us about MPT specialization.
Hello. Am I audible, madam?
Yes, sir.
Yeah. So basically, it is one is the inclination of the student. What the student is inclined, really passionate about. One is, another is like what long-term goals they have. Whether is it academic or is it clinical. So they need to be truly passionate about it, and say down the line. Timeline after 10 years or 15 years, what do they anticipate? What do they look themselves doing? So if they are passionate about academics or clinical, what area like appeals to them, whether it is a ICU where they would like to work, whether for cardiorespiratory, or though there are overlapping areas in the specialization, because we cannot totally exclude the areas as far as the specialization is concerned, because we are going to treat the entire person as a human being in the end. But most importantly is like the person has to actually take into account these things. What is his own interest? What is he passionate about? And how long that person would continue to love that subject even after 15 years or 20 years. So that would be the first question they should ask themselves, and they should have a clarity about the choice what they are going to make before opting for the subject what they will. Because study wise, all the subjects we need to study all the areas. So that is my
Thank you, sir.
opinion about it.
Yes, sir. So related with this, we have people asking us how to study anatomy and remember everything. So, and how to study community medicine. So, your expert tips on these two questions.
No, I like to add on the points what sir was discussing about the specialty area.
Sure, sir.
So,
Please.
so the recent trends what we observe in our practice areas or in my locality, whatever we see, there are few areas which can be explored further in master's program or in physiotherapy. The one area, primary area, is health promotion. Now there are a lot of things are happening within the society, like more of metabolic syndrome. What we say as early trends of cardiac events or obesity, all this hypertension, all this is going to happening in the society. So the specialization of health promotion is one of the important area which can be explored further. Other areas could be the onco-rehabilitation. Even I can see in my setup there is an increased trend of cancer diagnosis and the cancer rehabilitation. So that is other more area we can explore. And one more area which has not been much explored in India is about the women's health. The program for MDT, OBG, and gynecology. There are a lot of scope is available in the Western country, but still in India, this area is not much explored by our students. I'm not very sure about what are the facts related to it, but these are three common domains area which can have a lot of scope for physiotherapy with respect to health promotion, onco-rehabilitation, and women's health. That is my opinion with regard to the program.
I totally agree with sir.
Whatever you would like to add, sir. Dr. Deka, sir, please.
Yeah, regarding that, the last questions regarding anatomy and community medicine. So first I will speak on the community medicine only. The same book, the Community Health Perspective for Physiotherapy Students. So in that book itself, if you will read the first 2-3 chapters, the first 2-3 chapters will be the chapters which will make you understand about only the key terminology regarding what is prevention, treatment, and all. So when you are very clear with the basics or with the key terminology, then what will happen, that subject will be interesting to you. And once you gain the interest of the subject, then everything will be easy. But only thing what you need to do, you need to devote some time on a regular basis with that subject. Because the more you stay away from that subject, the more tougher will be the subject for you. So you have to regularly, first and foremost, you have to devote hours. Next is good book readings, and that book is basically will help you to make the understand, and plus you can take help of your teachers. So the teachers will further help you to make the subjects more interesting, and so on. In a due course of time, you will love the subject and it will become easy for you.
So I just add on to sir's opinion. We can name this book as Textbook of Community Physiotherapy, but we didn't name like that. We kept it as Community Health Perspectives. The word perspective has a wider meaning. So this textbook also given a wider meaning of what community physiotherapy addresses. So that's the reason we kept this book name as Community Health Perspectives for Physiotherapy Students rather than Textbook of Community Physiotherapy.
Hello? Hello?
Yes, sir.
Yeah, I would like to add on another thing as far as the anatomy and community medicine, or for that matter, any subject. Like there is a scientifically proven strategy, like to read a topic on the day when it is taught in the college by the teacher. So we have to read that topic on the same day from the textbook, not from any other sources, and revise it within 24 hours, read it once again, and the second revision will be within 7 days, and the third revision will be within 1 month. So this has a I don't remember the exact reference, but this has been like neurophysiologically, it has been endorsed by some of the people that it is a noted and tried and tested method to remember these concepts very easily for a very long period of time. And if possible, like what sir told, prepare the notes. That is the best, because even the few things what I remember now also was way 28 years back when I was the first year UG student. So still I remember that was what I also had practiced, preparing the notes and all those things. And following this scientific method would further reduce the time taken by the student to revise the topic at the time of exam especially. तो यूनिवर्सिटी एग्जाम्स का टेंशन बहुत कम हो जाता है उससे, because at that time they will require almost just 30% of the entire time to revise the same topic if they are going to do this systematic method. So that is from my side as far as this is concerned.
Thank you, sir. So that was the expert tips. I hope all the students are following through, and they will follow through these tips. At this point, I'd like to announce that we've launched the book today, and it will be available soon for everybody on different platforms on CBS PD and the official website, and Amazon, Flipkart, everywhere else with our online and offline dealers. It will be available soon, so you can get your copies from there. And Dr. Divya, would you like to add something?
I have been answering the questions, a lot of questions, student questions in the Q&A section. They had so many questions, we could not take up most of those. So I had been answering. I hope I've covered most of those. If anything is left, you can type your questions again. But let's be specific to the topic.
Okay, next, because a lot of people are asking for the PPTs also. So that's up to you. We can make your PPTs available to the students if the panelists want so. And that's up to their decisions. You will know on eCBS PD app when if the PPTs are available there.
We are happy.
Then we go to the.
From my side, yes, madam.
We are happy.
Yeah, we'll be happy.
Definitely, we can do that. We can add it to eCBS PD along with the rest of the digital content for this book. As soon as that goes live, we will add the PPTs also.
So that would be great for all students who've been asking for the PPT. You can download the eCBS PD app from Google Play, and all the content would be available there for this book. The next question, sir, can a physiotherapist adapt yoga to recover his or her patient, as yoga is a subject of BPT? This question is from Navjot again.
Each patient's conditions varies. Take example, two patients with stroke. So the two patients with stroke may be with the same disease conditions, but there will be some individual variations will be there. So personal, some factors changes are there, some environmental factors, then the severity of the disease state, the lesions of the disease state. Okay, then the goals, expectation from the therapist, then what is the patient's expectations. So all those factors are different. So based on the factors, and only thing important is what the patient needs at that point of care. Take example, if it is a acute care, or it is a subacute care, or it is a chronic care. So based on the need of the patient only, it will be decided. But no one treatment can treat or correct the overall lesions of the patients. We need the support of medical drugs also. Sometimes surgery is also required, sometimes psychological counseling or other therapy. So we cannot say it as a no, or we cannot say it as a yes, but it is entirely depend on the individual problems and what situations they are in.
So what sir about the comment on yoga, if you look into the literature for yoga, it's an ancient science. Okay. And it's a purely a different mode of approach, how to handle the life problems in any individual. So what is the perspective of yoga if most of us is doing some yoga? It is not about doing some yoga. It is the integration of mind, body with the spiritual connect. Okay, that's a component of yoga. So why it has been included in physiotherapy? It means like The therapist should have some adequate knowledge about of knowing the yoga, and he can recommend your client with the subject expert who is already being trained in some yoga. That is always better instead of physiotherapist integrating the yoga in his practice. But as we know that it's a science, so you need to have a pure scientific background of what type of yoga and what was the benefit with their activities and what it can be integrated in the mind level and spiritual level. Then only you can see the benefits of the yoga in physiotherapy. So my opinion is about this. If you want to feel that yoga can be integrated for this client, then you can refer the client to the expert opinion instead of you practicing or you are advising the yoga to the client.
The next question, sir, would you like to add something? Chandu sir,
No,
your
nothing
title.
from my side, madam.
Thank you. So the next question, how to check X-ray, CT scan, MRI film reports? I am not sure how the panelists will answer this question here.
See, always what I can suggest here is you specific to your domain. Okay, the topics which has been given in the curriculum is to know about what you should know in the X-ray or in the CT or in the MRI. You are not the expertise to diagnose from the X-ray and CT and MRI and to give the diagnosis to the client. Always you should have basic knowledge about what are the things you should screen or should look for in X-ray, CT or MRI. It is always better to discuss with the subject expert. That means here the radiologist. So you should always have an interaction with the radiologist to confirm with the diagnosis and to confirm your findings. Because as per my knowledge, that it's the syllabus what we have covering CT, MRI is to have some basic knowledge about the final conclusion of the diagnosis. Because in the CT and MRI, they write on diagnosis the final impression. If you read that impression as a health professional, you can be able to know what is the condition is. But if you take the film of MRI or T1, T2 images, there can be 7 to 8 films will be there. It is practically is not correct for our professionals to interpret each film what is happening in the particular films, because we are not a subject expert for this particular field. So my concern is when you want to read CT or MRI, it always better to have any new findings, interact with the first the subject expert, then you discuss with the client, rather than you only personally addressing that issue with the client.
So these days there are legal considerations also. If
Yes.
you'd like
Yes.
to point that
Yes.
out, that there is patient ownership issues and everything where legalities come up.
Yes, exactly.
So
Exactly.
between the physiotherapists, the radiotherapists, and the medical professionals and everybody. So that is also a consideration here. So moving on to the next question.
We like to limit our profession within our domain. That's always the recommendation. You keep your limitations, you keep your skills within your domain. If you want to do some further things, you interact or you make a discussion with the interdisciplinary team, then you work on with the client.
Absolutely, sir. So the next question, within the ICF framework, how can clinicians objectively measure the influence of parental attitudes and home environments on participation outcomes in children with cerebral palsy, independent of impairment severity? That's a long question.
The concern here is whatever the outcomes we measure right now in rehabilitation or in practice, each of the outcome measures have some limitation, because if you see the outcome measures what we do, either predominantly in the body impairment structure, or few outcome measures only the functional activities or the activity level, and few of the questionnaires talks about the quality of life and the participation. So always we don't have a particular scale or outcome which can measure all the 3 domains in the same percentage. So there are certain scales which are more dominantly addressing the body impairment. There are few scales that are more dominantly addressing the activity level. There are few scales talks only about participation level. If you want to address these things, there is a need to have an outcome measure which addresses all this component in a gender specific and age specific in a more broader perspective, rather than going for one unidimensional questionnaire. There is a need for that.
Plus, what I want to add is there is a ICF-1 checklist is there. In that checklist, everything has been they have defined based on the different level of functionings and all. And that is freely available. If you go to Google and all, you can directly download that ICF checklist, and in that ICF checklist all conditions and everything is given. So first, to identify those all other factors and all, so one have to go through that ICF checklist, and they have to understand, because this ICF, earlier the ICF is upgrade versions of actually ICD, International Classifications of Disease and all. So still now they are developing the different classifications based system in the functioning and all. So I think it will be not directly easy for a person to directly use the ICF in the clinical practice, because it requires lots of skill and effort, and plus it requires time also. So with more and more practice and with more and more use of the ICF, that checklist, I think we will be able to make it out of those all other factors.
Because I think ICF only needs a training program. It's a certificate training program. It's not like everyone can use the ICF. If you see the Western culture, Western population, each client they'll give the codes. They don't write the complaint as weakness of right upper limb. They will give codes with respect to ICF. If you see the document, only codes will be available. Those who are trained in ICF only can read the codes. But in India, it's not like that, because still we are not using the ICF code for documentation. But in Western culture, we are using the ICF codes for documentation, and each code can say about what is the body structure and impairment, what's activity level, and what's the impact level.
Thank you, sir. So we are also headed to 6:30, and we have to end soon. At this point, Jyoti Tanwar, she had some questions which have been answered by Dr. Divya and Dr. Apurva. And please explain the NALCN gene mutation. That's a question by Abhishek. So would you like to answer that?
Can you repeat the question? We are not able to hear it properly.
Please explain the NALCN gene mutation. I'm not sure if this pertains to the topic.
It's not relevant.
It's not relevant, right?
You can ask the participant to get a clear, like what are the things.
Yes. Okay. So I would request the audience to please stay confined to the topic. And the next question has been answered by Dr. Divya already on the chat. How physiotherapists should approach and treat the disabled persons to live their lives independently and barrier-free. So that's probably the last question that we will take, because we have to end the webinar by 6:30. So please answer this question, and we'll wind up after that. We'll have just the winner announcement. That will take just 5-10 minutes.
Hello, Dr. Rashi.
Yes, Dr. Divya.
Dr. Apurva this side.
So,
okay. Yeah, so the NALCN gene mutation is actually a very rare condition. It's a very rare neurological condition where you have developmental delays and intellectual disabilities, and it's not very commonly seen in India. So it's pertaining to the sodium leak channel. So that's all I know about it.
Not pertaining to today's. That's not relevant to today's topic, right?
Yes, it's not relevant to today's topic, but I think perhaps because we touched upon pediatric conditions, that's why this has raised up. But rest assured, it is a very rare case. You won't be seeing
rarely seen in India.
Yeah, you will not be seeing it very soon in your clinical practice.
So there, Abhishek, you have your answer. And the last question that I think sir was about to answer, how physiotherapists should approach and treat the disabled persons to live their life independently and barrier-free. That's the last question we'll take. For all the other questions, you can write to us. Our email IDs and everything is available on all our social media channels. So, and we'll get you connected with sir directly. His answers will be available to you.
As we said in this overall the discussion of today's is, the physiotherapy is one of the components to address the disability. It's more of like at different levels. It includes the individual, the family, the society, the government, and the policy, and the medical professionals. So in that medical professionals, one of the members is physiotherapy. First of all, we should know how much potential or the capability we have to address these issues. Because even I accept myself when I was preparing for the topic, I was exploring so many trusts of NGOs which can be helpful for the disabled people. Even though I'm there is profession for last 20 years, I'm not able to aware of all these things to help the disabled people. Once I start working on this work, then I see there are a lot of things are happening in India too. The first problem is like the therapists, what they're handling with that. They should have the potential to work with the different team, and they should have connect to the family and to the available resources. Whenever a patient getting discharged from the hospital or from your setup or clinics, you tell them what the next step process of integrating them into the society. That means you should tell that to the family members and the community, and also what are the resources available for their disabled child or an adult to next how to integrate into the community. The first thing is to be address their own potential and the capability, and to form a resource in the community so that to help them these disabled individual people into the community.
So I will add one more point. So for managing any disability, either it can be intellectual, physical, or so and so. So first we have to identify which approach we need to follow. Whether it should be a your already I spoke medical model or social model or biopsychosocial model. Second thing, whether it is not one man army work. So here we need a multidisciplinary approach, or maybe a interdisciplinary, or maybe a transdisciplinary approach. So that approach will help to clear all the issues, health related issues of a person who has been suffering or with a disability.
Thank you, sir. Do we have anything from Chandu, sir, to be added here, or I should conclude this section? So, okay.
Am I audible?
Yes, sir. Yes, sir.
Yeah, like again, it is an intercollaborative. Like everyone needs to step up and raise to the occasion, like including the patient, means right from the patient as well as the family members. Everyone should have a acceptance and also an open and a positive approach, where they are not anticipating miracle. Also, a systematic scientific approach under the guidance of the healthcare professionals, whether it is surgical or medical. So that would make it more realistic and more comprehensive, and phase-wise, scientifically proven strategies when employed, that would be more relevant and realistic. So that is what I wanted to add.
Thank you, sir. I will conclude the quick Q&A session here. And for all the attendees, now we have a very nice surprise. We were to announce 3 winners from among the attendees. We'll have a short poll, which will be like a rapid fire round. You will have the polls on your screens. As soon as possible, you have to click the answers as fast as possible, and then we'll announce the winners. So may I request the backend team to please play the polls.
I would like to congratulate Dr. Kuldeep and Dr. Vijay Kumar for the book. Finally, we have that in our hands today.
Thank you.
That's at least a couple of years of hard work.
Yes.
I thank Kuldeep sir and Vijay Kumar sir for this wonderful opportunity. Actually, they were the one who inspired me to write this topics, be contributor for this, and all this backend support from the CBS team. So actually, though it was a bit of more challenging for me, considering the administrative responsibilities also, but good. And it has boosted up my confidence, sir. Thank you once again. Thank you.
Thanks to you also, sir, for giving so much of support throughout these last 2 years.
Yes, sir. Because when you are discussing about this to Chandu sir was initially no Vijay, I can't do this. I have a lot of things. I have not written so many things. Then we suggested him, sir, you just have a look. It's a good chance to put your passion into the budding physiotherapy so that it can take over the next generation. So we heartily thankful to sir for his valuable time and contribution and his dedication for this book. Thank you, sir.
Yes, sir. Definitely. That time I was really very much challenged considering the deemed university where I was working, because a lot of administrative challenges I was facing, and a lot because it was right from framing the entire syllabus, uh, switching on from the semester mode to the annual mode, and all those things was going on. So I was overburdened with less staff and all those things. But
But sir,
definitely your
this
support has made
responsibility,
me
so this
has helped me.
responsibility of providing credible, genuine academic resource material also lies on your shoulders of such experienced and renowned academicians. So we understand you had a lot of responsibilities, but this we added this one onto your shoulders, and it's been
No, but it was good,
a
madam.
great
It was
experience.
good. I feel I have been more strengthened. So I am thankful to both of them that they trusted me and kept on pushing me towards the goal.
Wonderful.
Okay, so we have seen a lot of participation in the polls, and we'll announce the winners shortly. Give us just 5 minutes.
I'll just take a moment to also tell that this book was also released in the recent 11th INCPT AIMS conference.
So thank you everybody for the patience. Our team has analyzed the polls and we are out with 3 winners. Now because of this some technical glitch, I'm unable to send the winners' names to our panelists. That's why I am announcing them. The first book has been backed by Mohammed Mujtaba. This is Investigation Simplified. Can you spot it? By Vrushali Panhale, Shruti Nair, and Prachita Valankar. The next winner, the second winner, is Rachna Vashisht. She gets CBS Physiotherapy Dictionary for students and practitioners. That's by CBS. And the third winner is Praful Boyer, Decode Physiotherapy through MCQs. So congratulations all the winners. The books will reach your doorstep within a week's time. And meanwhile, it's also 6:30. So we'd like to conclude here. It was a wonderful evening with our panelists, with our authors, Dr. Vijay Kumar and Dr. Deka, our experts, Dr. Chandu, Dr. Divya, and Dr. Apurva. On behalf of CBS, I'd like to thank all of you for giving us your time and for this book launch.
Thank you.
Thank you.
All the students. Madam, I also thank all the students for their patient listening despite 2.5 hours. Still,
Absolutely, sir. We'd like to thank all the lovely audience out there. We had principals and teachers and students from different physiotherapy colleges from Pan India. So we'd like to thank all of you. And for those of you who've not won today, please follow our pages. Be a part of our community. We run a lot of contests there. There are quizzes and there are videos and this and that. So you get a lot of opportunities to, bag good prizes, good CBS books as prizes. So I love to see all of you there.
Thank you.
So now let's conclude. Thank you, all of you. Thank you.
Thank you.
We're signing off.
Thank you, one and all.
Thank you.